please.
Good afternoon, everyone. I am Dr. Khoa, representing the research team from the Department of Nuclear Medicine at the 108 Military Central Hospital. Today is my honor to present our study on the prognostic value of 18f-fdg PET-CT for predicting post-transplant recurrence in hepatocellular carcinoma. So HCC represents a significant global health burden. In Vietnam, it ranks as the leading cause of morbidity and mortality. And liver transplantation is widely regarded as the most effective curative treatment for HCC. However, a major challenge persists, which is the post-transplantation recurrence rate remains high, affecting from 20 to 30% of patients. So selecting suitable candidates is essential to optimize survival outcome and make efficient use of limited liver grafts. The Milan criteria proposed in 1996 by a team of Italian doctors are considered the gold standard for selecting patients for liver transplantation. Adherence to these criteria has been associated with a 4-year recurrence-free survival rate of 75%. Over the years, several other criteria like UNOS or UCSF has been developed to minimize the recurrence rate. However, current criteria like Milan and UCSF, along with prognostic biomarker such as the AFP or PIVCA2 levels and histopathological features, all have certain limitations. Recently, the imaging provided by PET-CT has been shown in various studies to be highly effective in predicting post-transplant recurrence. Several international studies have demonstrated that patients whose tumors show no FDG uptake refers as a negative PET-CT experience significantly longer recurrence-free and overall survival compared to the group with FDG-avid tumors. Furthermore, quantitative parameters that assess tumor metabolism, such as SUV max, SUV mean, SUV peak, and parameters that quantify the overall tumor burden like the MTV and TLG, have also reported to be strongly associated with low recurrence rate. In Vietnam, the number of patients with HCC undergoing donor liver transplantation remains limited, approximately 150 cases reported, and no research has yet explored the role of FDG PET-CT in evaluating prognosis following LGDT in HCC patients. So our study is to evaluate the prognostic value of FDG uptake characteristic and metabolic parameters on whole body FDG images in HCC patients after leaving donor liver transplantation. The study design is the retrospective and cross-sectional study. The patients were selected who underwent PET-CT and subsequent liver donor transplantation for HCC. So time is from January 2019 to May 2024. The location in the 108 Military Central Hospital. In our study, patients who were deemed clinically eligible for liver transplantation and had a suitable donor underwent a whole body PET scan. This software automatically calculates various parameters using an adaptive thresholding method to segment the tumor or voxels within the region of interest, having an SUV equal or greater than the threshold were identified as part of the tumor, indicating high metabolic activity and will classify as positive PET-CT. Conversely, a negative PET-CT is the tumor which show no FDG uptake. After discharge, patients were managed according to the standard outpatient protocol and had scheduled follow-up at the Department of Hepatobiliary Pancreatic Surgery at the 108 Hospital. The recurrence was determined based on imaging findings or histopathological confirmation. The variables include general characteristic, history, clinical and paraclinical characteristic. About FDG PET-CT, we analyze the primary tumor lesions with or without the increased FDG uptake and metabolic parameters SUV max, SUV mean, SUV peak, MTV, and TLG. The recurrence-free survival is defined from the date of liver transplantation until disease recurrence, that or the conclusion of the study. After excluding unmatched criteria patients, 39 patients were included in the study. A total of 39% of patients were enrolled in the study with a median follow-up period of 22 months approximately. During this time, 8 patients experienced recurrence corresponding to a recurrence rate of 20.5%. The size of recurrence included the liver, lungs, renal glands, and bone. The cohort was predominantly male with 37 patients, accounting for 95% of the group. The majority of patients had underlying liver disease, which hepatitis B infection being the most common. In terms of selection criteria, 46% of patients were within the Milan criteria, and 41% show the FDG avid tumors. The majority of our patients had undergone other treatments prior to the liver transplantation. Only 5% received a transplant at the time of the initial diagnosis. Local regional therapies such as TAC, liver resection, or IFA were frequently utilized. When comparing the characteristics between the two groups, it was found that the levels of AFP and PIFGA2 levels were higher in the recurrence group and statistically significantly. This group also had a significantly higher proportion of non-compliance with Milan criteria and T4 or T3 stage. Regarding the PET-CT factors, the proportion of patients with positive in the recurrence group was much higher than in the non-recurrence group. Regarding quantitative assessments, the metabolic parameters like SUV max, SUV peak, MTV, and TLG in the recurrence group were all higher than the other group. Using the Kaplan-Meier method to analyze recurrence-free survival, we observed that patients who met the Milan criteria had a 4-year RS rate of 87.5%. And patients with the PET-CT negative had a RS rate after 4 years is 83.7%. These findings are consistent with many international studies, which also show that patients with a negative PET-CT uptake have a lower recurrence rate compared to those who are positive PET-CT. For the negative PET-CT group, the 5-year recurrence-free survival rate ranged from 76 to 93.3%. Especially when we combined both factors, we found that patients who were outside the Milan criteria but show negative PET-CT result had a 4-year recurrence-free survival rate that was comparable to the group of patients who met the Milan criteria. We then used the ROP curve analysis to determine the optimal cutoff values for predicting FS. Our analysis showed that almost metabolic parameters were statistically significant, with the AUC ranging from 0.75 to 77. Applying this cutoff value to the Kaplan-Meier analysis further confirmed that their prognostic power. We observed a statistically significant difference in post-transplant recurrence between patients above and below the threshold for all parameters. We compare our findings with 2022 study by Kang and Alliance, which also focused on 49% of patients undergoing liver transplantation. They similarly found that the patient with the tumor SUV mark greater than 4.6 had a higher post-transplant recurrent rate. In our univariate cost regression analysis, several factors were found to be significantly associated with post-transplant recurrence, including FDG avid tumors, the various metabolic parameters, and the PIFGA2 level. However, in our multivariate analysis, none of these factors emerged as an independent prognostic predictor. So this is a retrospective study, and we still have our own limitation. And because it was a study in a single center with a small sample size. And most patients have been treated by local therapy before the liver transplantation, so PET-CT may not fully reflect the biological characteristic of the primary tumor. And many patients underwent PET-CT a facility outside the research unit, and many will not follow up periodically after the liver transplantation. So we want to have some conclusion that FDG uptake characteristic and metabolic parameters on PET-CT have highly prognostic value on predicting post-liver transplantation recurrence of HCC patient. And it is possible to combine the PET-CT characteristic with other factors to expand the criteria for selecting suitable gap transplant candidates with low recurrent prognosis, helping to improve the quality of treatment. And prospective multi-center studies are needed to further determine the value of FDG PET-CT in predicting RS and OS after the liver transplantation. Thank you.